Assalamu alaikum, the long clinical consultation day. First scenario, 48 years old, Mr. Tim presented with complaint of vomiting of blood. Pulse rate 120, blood pressure 90/70, past history of diabetes. Please take history and examine the patient. Ready?
Yes, I'm ready. Hello, I'm Dr. Henry, one of the doctors here. May I please confirm you are Mr. Tim, 48 years old?
Yes, doctor.
Okay, I'll be taking some details from you and then examining you, and then I'll address your concern. Can I please go ahead?
Yes, please.
All right, I just went through your notes and I understood you have been having some complaint. Could you throw more light about your condition?
Well, doctor, I am in trouble. I'm throwing out blood,
Oh,
I'm
so
just
sorry to hear
vomiting
about
blood.
So sorry to hear about that, Mr. Tim. We will see what you can do to address that. If I may ask, for how long have you been throwing out blood?
Well,
Sorry.
doctor, yeah. Well, doctor, it's been happening for the last 1 day, I might say.
Okay.
Yeah.
So, is it the first time you have been throwing out blood, or you've had that episode before?
No, that's the first time exactly.
Oh, okay. If you want to quantify the amount of blood you throw up, how much will it be?
I have no idea, doctor. I'm just throwing out blood. I
Okay.
don't
Was it
know.
much? Or was it okay? You can't certain. Okay. Do you also have bleeding? Do you also have bleeding in any part of your body outside your? Hmm?
No,
Oh,
no,
okay.
no. I'm just
Okay.
throwing out blood.
Was there any clotted blood?
Sorry?
Was the blood clotted? Was it clotted?
It's just bright blood mixed up with the stuff I have eaten, and I can't eat anymore. So it's all blood now, mostly.
Oh, okay. So sorry about that. Have you ever passed any dark stool?
Past any, sorry?
Have you ever passed any dark stool? Dark stool. Your bowel movement, has it been dark in color?
No,
No.
doctor.
Oh, okay. Do you have any tummy pain?
I feel like, I don't feel tummy pain, but I feel like, my chest is burning.
Okay, chest is burning. So sorry about that. Do you feel as if the burning sensation you're feeling, does it go to the back? Do you feel it also at the back of your chest?
No, not like that, doctor.
Oh, okay. And is there any do you notice that probably you have been feeling dizzy?
Yeah, doctor, I'm feeling weak, I'm throwing out blood.
Oh, okay. All right. Any feeling sick, as in as if you want to throw up, like not feeling sick?
Yeah, because of, I'm throwing out blood, so you can well imagine. I'm not feeling okay, I'm
Okay.
feeling sick.
All right. Any tummy swelling?
Nothing that I have noticed.
Okay. Any passing of loose stool or hard stool?
My stool is normal. I haven't noticed, doctor. But it's normal.
Okay. Any mouth sore?
No, doctor.
Okay. Any difficulty in swallowing?
I can't swallow anything. I'm just throwing out blood.
Okay, you can't swallow anything. For how long have you been having difficulty in swallowing? For how long?
I haven't checked myself because I'm throwing blood, so I'm scared, doctor, because of that.
Okay, before this from train out of blood, have you been having any difficulty in swallowing before now?
No, doctor.
Okay, do you took any maybe medication like over the counter medication prior to that time, before that time?
No, doctor.
Okay. Any fall? Have you fallen down? Maybe because of the dizziness. Did you fall down?
No, I haven't fallen, doctor.
Any weight loss or weight gain?
No, doctor. I haven't noticed that. I do feel a little weak, doctor.
Okay. Any hotness of the body?
Sorry?
Any hotness of the body? Fever? Any
No,
hotness of the
doctor.
body?
No, doctor.
Any night sweats?
Uh, I feel like, if I don't feel sweaty, but I feel like my heart is racing and everything.
Okay. I understood you have been having diabetes. For how long have you been having this diabetes?
Well, I've been diabetic for 15 years.
15 years. Okay. Are you regular on your medication and clinic follow-up?
I'm casual about it, doctor.
Okay. So when was the last time you went to the clinic and check your blood sugar?
I'm not regular about it.
Okay.
The last time the last time they got tested me from some test they call HbA1c, it was around 9.
Okay. All right. Have you after the diabetes? Have you been having any other condition?
Uh, Doctor, apart from that, I'm taking in this medicine. They call it uh, SSRIs because I,
SSRI.
I can't
Okay.
sleep properly and I'm
Oh,
stressed out all the time.
okay.
Yeah.
Okay. For how long, as in, who prescribed this medication for you, and for how long you have been taking them?
My previous doctor.
Okay. Okay. But has it been helping you out for your sleep? Has it been helping you out for your sleep?
Is it? Sorry?
Has it been helping out with your sleep? Has the
Yeah,
medication been helping?
it is helping me. It is helping me.
Okay.
Yeah.
Okay. Okay. Then outside this feeling of sleepiness, any other complaint, like let's say um chest pain that has been there for a very long time? This
Uh, right now, I'm having uneasiness in my chest, but not of that kind, doctor. Because
okay.
maybe I'm throwing out blood because of that. I do get body pains, and I do get painkillers for them sometimes. Like,
Okay. So for how long have you been taking these painkillers?
uh, I take it casually. When a pain gets over me, I take it. Normally, I can tolerate it, but
Okay.
sometimes, I take it.
Okay. Concerning the have you had any surgery in the past?
Uh, Not that I know of.
Any recent admission or procedure done in the past?
Well, but one of the doctor did told me to get checked because I found that I look more pale, and he was telling me that you have that yellowish tinge to your skin, maybe. He did tell me, but I didn't bother to go to hospital.
Okay. All right. Okay. Do you have any itching of the body? Do you feel as if your body is itching?
No, doctor.
Okay. And any maybe notice that you have been having this okay, I've asked you about that. Okay, sorry, this is more personal question. Do you have any drug allergy?
No, doctor.
Any family issue of any liver problem or
Mm, No, doctor.
any family issue? Okay, have you had any history of maybe contact with maybe use of sharps or unsterilized sharps?
Uh, no, doctor.
Okay, what's up? Sorry, whom do you live with?
I live alone, doctor.
Okay, what kind of job do you do?
Uh, I used to be a gym person, a fitness person, fitness guy, fitness instructor. But
Okay, I'm
lately,
not okay. Go
yeah,
ahead, so
lately I have crashed, so my health is going down way, and I left it.
your health is going down. Could you tell me more? I don't understand what do you mean your health is going down. What has been wrong with you?
I don't know, doctor. I'm not happy with my life sometimes.
Okay. All right. How this condition affect your daily life?
Well, doctor, what do you mean by daily life? I'm alone, just that. Me and my thoughts.
Okay. All right. Let me ask. Sorry. Do you smoke?
Yeah, I smoke
Okay. How many sticks have you been smoking and for how long per day?
12 sticks a day, and for the last 5 years.
Okay. All right. Do you take alcohol?
Yeah, doctor.
Okay. For how long have you been drinking? How many units per day or per week?
Well, I get a can of beer every night almost.
Okay. All right. Smoking and cigarettes can be dangerous to your health. With your permission, I might help to refer you to the smoking and alcohol cessation clinic so they can help you out. Is that okay?
I appreciate that, doctor.
Okay. Do you drive?
I don't drive, doctor.
Okay. If I may ask, sorry, do you have any casual partner?
I don't have any casual partner.
Any recent travel?
No, doctor.
Okay. This is more. Do you have any headache?
No, doctor.
Any blurring of vision?
No, doctor.
Any loss of consciousness?
No.
Okay. Any neck pain or neck swelling?
I feel like my, the jaw area of mine has got a little swollen.
Pardon?
My jaw on both sides.
Your
I
jaw.
feel that it's a little swollen and grown.
Okay, all right. And okay, I see you've not had any weight loss, right? Okay. Any pins and needle sensation?
No, doctor.
Okay. Any difficulty in standing from sitting position?
No, doctor.
Okay. Any problem with passing urine?
No, doctor.
Any problem with passing stool?
No, doctor.
And any joint pain?
Not that much.
Okay. Do you mind if I examine you?
Yes, please, doctor.
Okay. I want to start with looking at your hands. Any palmar erythema, any deepening contraction, any
I will
clubbing?
share the picture of my outlook, doctor. How I look now and how I used to look before.
Okay.
I've shared it in the group.
Okay. Any what's the pulse rate? Okay, I've seen the pulse. Any scars in the body?
I don't have any scars in the body, doctor.
Okay. Any jaundice?
Yeah, my palm are red,
Okay.
they have a reddish hue,
Okay.
and
Any loss of
my skin is pale.
your skin is pale?
I have a scleral icterus, and my muscles of shoulder are wasted, and my tummy is grown, as you can see in the picture. The
I
left
can't
part
see.
is me now. The left
I
part
can't
is
really.
me now.
I can't really see it now. Anyway.
It's
Okay.
it's in the WhatsApp, doctor.
Okay. I want to check the abdomen. Okay, that's the abdomen. Okay, I've seen it. Okay. Okay. Then I look at your eyes. And okay, which one is the correct one? Sorry, the one at the
Yeah,
left.
my abdomen is distended.
Okay. Then I want to look at anything in the mouth. Anything in the mouth. Any dehydration. I've seen the jaundice. I've seen any pallor in the eyes. Is there
Yes,
pallor?
pallor in the eye, scleral icterus, pallor in the eye.
Okay, then look at the tummy. Any hepatomegaly?
You can say, yeah, there is.
Yes, okay. Okay. Check the liver and spleen. Check the kidneys. Anything?
Spleen is enlarged.
Spleen is enlarged. Okay. Then any ascites?
Yes.
Okay. Then check this. Then auscultates. Any bowel sound?
Yeah.
Any brew?
Hyperactive bowel sounds.
Okay. Okay. Then I check for the neck. Check for the lymph nodes. Any lymph nodes?
No.
Out of the neck, the jaw. The one you complain about some lumps in the neck. Anything?
Yeah, my parotids. I would say it
Okay.
by my own mouth. My parotids
Okay.
are enlarged.
Any loss of axillary hair?
2 minutes.
No.
Any loss of axillary hair? Loss of axillary hair?
No.
Okay. Do you have any concern?
Doctor, what's wrong with me?
Mr. Tim, I
I'm
believe
throwing
there's
out
something.
blood.
Yeah, there are a lot of things that's going through my mind. It could be that probably you're having a liver condition because your liver is quite enlarged, and there are some things I'm seeing that it's keeping with liver problem. That might be the reason why we are throwing off blood. And it could also be that because of the medication you are taking. Oh, yeah, the medication you are taking for the pain. That can also be the cause. However, not to worry, we'll do some tests for you. We'll admit you as it is, then evaluate you. Then with other doctors will come and also review you, including the tummy doctors and the doctor that we are there. But at the meantime, I'm going to give you some fluid through your blood channels, and then do some baseline test. And after your blood pressure has come, improved, I'm going to do some camera tests to know where the points of bleeding. Any other concern?
Doctor, will I survive?
we'll do our best. I must say, we'll do our best. The good thing that you came in early, and currently your vitals are not very bad, but we'll do our best to ensure that you get the utmost care. Any other concern?
No, doctor. Thank you.
All right, I will send the
Please
nurses to
describe
take.
this.
Okay, I've seen this Mr. 48 years old Mr. Tom, who presented an account of vomiting of blood. There's also a history of epigastric pain, however, not radiating, and there's which is said to be burning in sensation, does not radiate. He is in a gym. He works in the gym. However, for the past few period, he has not been going to work because of his illness. There's also a history of abdominal swelling. There's issue of abdominal swelling. However, no family issue of liver disease, or there's also have a complete yellowish discoloration of the eyes with swelling around both jaws. He smokes and take alcohol significantly. On examination findings, with also evidence of feeling dizzy. On examination findings, is pale aninteric with evidence of primary erythema. However, I couldn't appreciate any spider nevi, no loss of axillary hair with parotid fullness. Abdominal seemed to be distended with hepatosplenomegaly with ascites. However, bowel sounds are hyperactive with no bile on the liver and spleen. The general, these are my findings.
Doctor,
Yes.
Tim came to you and he's talking to you about throwing up blood, his pulse, his BP. What would you
Yes.
do?
Pardon?
I mean, just asking. Look at the vitals. So would you like to admit Mr. Tim?
Yes, I told him I'm going to admit him. I told him I'm going to admit him.
Okay.
Yes, I told him I'm going to admit him. I told him I'm going to do some blood tests and then camera tests for him. I also told him that I'm going to invite some doctor that will also manage the complications. I told him that. I did.
Can you give me your differentials for this, Mr. Tim?
My differentials for the cause of my differentials for this case will be variceal bleeding, likely due to chronic liver disease. Secondary to alcoholic liver disease. Also, could also be due secondary to alcoholic liver disease. Other differential diagnosis in this case could be bleeding peptic ulcer disease, likely to also bleeding bleeding peptic ulcer disease, yes, and also could also due to gastritis from NSAID, from prolonged NSAID use. These are my three other differential diagnoses in this case. Other thing I want to consider could be due to Bohaf syndrome, Mallory-West tear, and also maybe due to GIF. Yeah, these are my likely differentials. Yeah.
Okay. One more thing, doctor. If you have to do some investigations, I would ask, what would be those investigations, knowing the fact that he's throwing out blood and it's a case of chronic liver disease or liver cirrhosis, as you have put it? What will be the major investigation that you would be doing here?
Yeah, in the interim, after patient is stable, we want to within the first 12 hours after patient is stable, we want to do an upper GI endoscopy, which we likely which is the confirmatory investigation to get the source of bleeding. That will tell us, it can tell us the cause, and then help to also prognosticate the individual. Other investigation we want to do is liver function test, hepatitis profile. I also want to do baseline full blood count, and to check for the evidence of to rule out alcoholic liver disease, which I expect to see macrocytic anemia, and also I expect to see raised AST in liver function test. I also expect to see evidence of these are then also urine deep electrolytes, urea and creatinine to rule out additional AKI or acute kidney injury. Also in this patient, I also want to do abdominal ultrasound scan and also which can further tell us if it's the level of the liver enlargement and also other complications, maybe will in this case. And also want to do a CT of the abdomen, also to, and same time do elastography.
Okay, why CT abdomen?
Yeah, CT abdomen. Yeah, CT abdomen we give us if there's any evidence of, before that, give if there's any intra-abdominal.
Are you trying to say that you want to do fibroscan, or you're saying that you want to do CT abdomen?
Yeah, I mentioned fibroscan for that's elastography. That will tell us the degree of cirrhosis in this patient.
Okay, doctor. Now, come to the medications that you would use intravenously. What would be that?
At this point in time, I want to start him on telepressin, which has been shown to be important in variceal bleeding. And telepressin, or probably telepressin first line. Yeah.
Mm-hmm. And do you want to give something as a prophylaxis? Do you think?
Yeah.
Would
for prophylaxis, some beta blocker, which has been shown to, such as propranolol or carvedilol, has been shown to also, help in the interim too, and also as a prophylaxis too. However, in this case, I don't think with the patient the definitive treatment in this case is to variceal band ligation. That's the definitive treatment in this case.
Yeah, very good. Thank you.
I have one important question, Dr. Henry. What is the blood workup? Could be as general or baseline, but in this condition, it must be specific one.
Yeah.
It's one of the tests, investigation. You are doing it as routine. But in this situation, you will do it as a specific one. What is it?
Yes. That's the liver function test, and also the full blood count, both of them.
You mentioned it, but you didn't mention the one I wanted. You mentioned liver function. You mentioned also CBC.
Yeah.
Something very important, and in this situation, it might be abnormal.
Also, kidney function test, electrolyte and creatinine.
No, something. As I said, it's routine test, and every patient will be admitted to the hospital. In this scenario,
the sugar because of the diabetes.
No, still.
Okay.
Again, routine investigation. You are doing it for every person admitted to the hospital. In this scenario, it will be very specific one, and according to it, you have to do more action. If you found some change in the levels. Anyone knows?
Routine test.
Clotting screen.
Sorry?
Could it be a clotting screen now? Or
Yes, exactly.
Yes.
Coagulation profile.
Profile.
Bleeding patient, you have to do INR, PTT, EBT. Coagulation profile is one of the important baseline tests for any patient. In this scenario, it would be more specific because it includes the clotting factor, which is very specific for liver disease, right? You didn't mention it, and it's very important for any bleeding patient. Are you agree, Dr. Henry? Did you mention it?
You didn't give me a chance to.
No, I give it, Dr. Henry.
No, you didn't. Okay, I didn't mention it's quite right, but the way you asked about the investigation, it says
it's okay.
I didn't mention it.
At least you will remember it whenever you forget it.
Yeah,
next,
I did not.
Okay?
That's true, yeah.
It's okay. Thank you, Dr. Renari. Dr. Ibu, you can comment now.
Yes, sir. So what I will do, I have put the DDs of this case. First of all, I will talk about the DDs of this case, and I put it in the WhatsApp group, sir. You can see it clearly. Everyone can see it. And Dr. Henry was very spot on in terms of DDs. He was very good with the DDs. I will have to comment about some of the things that he missed out, though he was very good with the DDs. Appreciate that. questions regarding the history that he was taking. He asked about the nature. Okay, he tried to ask about the volume. Okay, tried to ask about the presence of clots. Then onset, food first or blood first. A little question about that would have been better. He asked about blood in the stool. That's good. He asked about any problem with the digestion. That's also good. A little about, I would say that he could have asked me about a little about confusion, my sleep. How's my sleep? Am I irritable? How is my mood? Because that bleed and that thing with my liver has created a tendency of hepatic incaf as well, which will be very much evident when he's examining me. When he's examining me, there will be flap, right? I guess Dr. Henry didn't mention that indication towards he would be checking the flap as well. In my case, it was there because it was a bleed. My liver was not okay for a longer time. I was diabetic as well. My diabetic control was not okay. So all of those things were affecting my liver. Okay. Okay. Anyhow, then a little question about diabetes. He did ask me. He did ask me about the control of it. He should have a little asked me about the medications that I use. Yes, he did ask me about the medications that I use alongside. I'm using SSRIs and it also increased the tendency of bleed. That's very important. Alcohol history, quantifying the alcohol history, that was done. But I think, Dr. Henry, you didn't ask me over how long I'm taking alcohol. You didn't ask me that.
No.
Like quantification, just for the sake of knowing that, my liver is damaged because of the chronic alcohol consumption. Otherwise, it was superb. And then when it comes to vital signs, you should have asked for the postural drop, offering the postural drop of BP, offering. It's already low, already very low on the lower side, and will go low further if postural drop. Although, by the way, in this case, postural drop should not be offered, but still checking for postural drop in such case is important as well. You can ask, you can offer, you can say that. Skin temperature, capillary refill, hands, pulmonary edema is there, repeated contracture, flapping tremor is there, parotid are enlarged, there is spider nevi, there is muscle wasting as I've shown you the picture. My previous body was like more of athlete, more of a gym instructor, and the current status is like shredded muscles are gone, and belly fat is too much. So yeah, you asked it, I showed you that. There is hepatomegaly, splenomegaly, shifting dullness, bowel sounds are hyperactive. Why? Because of the GI bleed. Bowel sounds are active because of the risk GI bleeding. You can offer DRE, by the way. At the end, you can verbally say to the examiner that I would like to offer DRE. Very important in case of bleed. Very important is that. And then when it comes to investigation, you will do bedside, like you can offer urine output because, his vitals are crashing, like his pulse is high, BP is going down. You can offer urine output. Then cross-matching type and screen, cross-match blood. That's very important when it comes to managing this case. Full blood count, as Dr. Basim said, the coagulation profile is very important. LFTs and albumin, urea and electrolytes. And one of the most important thing is that isolated, disproportionately elevated urea with normal creatinine is a strong criteria for upper GI bleed. That's very important thing. Although it's very much towards the clinical side, I'm not blaming anybody, but it's a learning point for all of us. And capillary blood glucose is diabetic. You can ask, you can offer. Upper GI endoscopy is the gold standard. Yeah. So yeah, and ideally should be performed within 24 hours of admission there and then. Then you go with airway, breathing, circulation, putting two cannulas, resuscitation of fluids and blood, and IV terlipressin. That's very well said. Ceftriaxone, why? Because you need to do antibiotic prophylaxis. There's a risk of spontaneous bacterial peritonitis. Acid suppression, you should be giving pantoprazole, 80 milligram IV bolus. And then ultimately you go with, if you find the viruses, you go with endoscopic variceal band ligation. That's how you go with ultimately. And if non-variceal, like peptic ulcer disease, like you have very well said, Mr. Dr. Henry, you can do clip application, you can do thermal coagulation or adrenaline injection. And in case if it's refractory varicose bleed, you can say Sangstecken Blackmore tube, or the definitive would be TIPS. TIPS. Did you mention TIPS? That's the definitive. If it's a refractory varicose bleed, if it's unable to be controlled, even after doing all that, TIPS. And secondary prophylaxis you can do with non-selective beta blocker. You were very right when you said propranolol or carvedilol. Then you should talk about diabetes optimization, alcohol cessation, and cirrhosis surveillance is very important in such case as well. That's it. That's my take on it.
Hold on, Dr. Ebu. Dr. Ebu, you did not ask me to manage this patient. Your question was just like direct questions. You did not ask me to talk about the management of this patient. So that's why I did not. You are just answering some of your questions you asked. You say, okay, which medication would give to proof? You are just asking me direct questions. You didn't ask me to manage. That's why I could not settle down.
No. Yeah,
Talk
you're
about
right
the
in that.
MDT.
No, I was
Yeah.
trying to squeeze it to make it easy for you.
Okay.
I did tell you that how would you proceed? When I tell proceed, like for example, my first picture that I had sent, I said proceed. It includes everything.
Okay,
You
because I was starting. You're asking me which medication will be given for this.
Yes,
which
I was trying
injection
to,
will be given for this.
and you answered correctly. I'm not criticizing you. You answered correctly. I was trying to add up this thing. That's how
Okay.
you would proceed with that.
Okay. Thank you.
Okay, thank you, Dr. Ibu. I will ask you, Dr. Henry, one more question, and I will give you the all time to answer it. Okay?
Okay.
From the picture, what you can add to your differential diagnosis? From the picture.
From the pictures.
Yeah. Look at the picture.
As in the patient picture.
In the chat box.
Sorry, let me see the chat box. 1 minute, sorry. Let me go back to it.
Yeah.
So 1 minute, let me see chat box.
I'm sorry if my pictures are causing disruption, Dr. Basim sir.
No.
Is it as the differential diagnosis or what? Sorry.
Yes, it will add one differential to your differential diagnosis, as well as you have to learn how to get inspection findings before examining the patient, just by the look, from first sight.
Yeah. Because the variceal bleeding could be due to metabolic syndrome.
No.
From
No.
Because he has diabetes, he has okay, sorry.
Yeah.
From the guy's picture.
No. Metabolic, you will have a obese patient. This is masculine guy, and he's not at all obese.
Okay. From the patient, because of the tattoo, the viral hepatitis.
Yes, exactly. See, this is one of the important findings by only inspection. It will add one important differential to your list. Even you can add one question or more question about this tattoo if you suspect HBV or hepatitis B virus, right? Or hepatitis C, whatever the infectious cause. Okay, thank you, Dr. Henry. Tattooing, perfect. And not only that, really, I give you the first question. I ask you the question 3 times. So I give you the time to answer, but you didn't get the question.
Okay, the iron arrow.
Yeah, exactly. Okay, you will not forget it again. Okay, let's go to the skills. I think, and I believe you did this scenario perfect. Some points missed, yes, but just complimentary comment to Dr. Ibu. He did very nice comment and rationale to his talk. So I will add to his finding on physical examination. And he told you, he was volunteered to say to you that he has parotid swelling. So it will be supportive for what? More conclusive for what? If you have parotid swelling.
Alcoholic liver disease.
Exactly. Along with, in the hand, you might have what?
Deep contraction.
Perfect.
Yeah.
Okay, and this patient, I think he has both of them, or at least parotid. Parotid swelling, it will be more conclusive to alcoholic hepatic liver disease. So be sure that you examine all these things whenever you have it in the history. Or if you don't have it in the history, you can examine it during the examination, just to show the examiner I would like to examine the parotid for parotid swelling. Okay, this is for physical examination. Apart from that, I think you did everything. Apart also from the tattoo, you have to mention patient is having tattooing, and if you don't ask it in the history, what about your tattoo, or you have any history of tattooing, I should ask about how was the circumstances he was having this tattooing. Okay, was it clean or no? This is regarding the physical examination. So you missed maybe the parotid as well as the tattooing and also the vitals. I don't know if you ask about vitals when you start to examine the patient. If you
I
didn't
did.
ask,
I asked, but then he bringing the pictures. I asked about the pulse rate, the BP, but he was bringing the picture. But I didn't do posterior blood pressure. As of the blood pressure and BP and the pulse rate, but I didn't do posterior hypertension. I did not
okay,
check.
the pulse volume, the
No, I
blood
did. I
pressure.
just asked, I didn't check for pulse volume. I just asked for pulse rate.
Yeah,
The
I'm
pulse
trying
rate.
to make everything clear for others. Pulse volume, blood pressure sitting, standing, or you offer posture hypotension.
No,
You
I
can
did
ask
not.
the
I did
examiner.
not.
Yeah, parotid, the between contracture, as well as the tattooing, and as Dr. Ibu said, offer DRE, digital rectal examination. By this way, you can get the 4 mark in the physical examination. Next, for identify the signs, the same as we did, but you will tell about the positive finding. Tattooing and the train and the parotid, ascites, either shifting dullness or thrill if there is, hepatomegaly, splenomegaly if there is, spider nevi, axillary hair, gynecomastia, all the features of chronic liver disease you have to examine and to mention if it was positive. Then the clinical communication skill. I guess you did perfect in all. You didn't miss any history, which is perfect point. Apart from HIV history or the risk habit, tattooing. Otherwise, all history you asked. Don't forget also to add, whenever you have elderly patient, you can ask about blood transfusion, any history of blood transfusion. Okay? Can give you a clue for HIV or hepatitis B or C. Then the next point for differential diagnosis. If you have the tattoo, you can add to your differential the alcohol and the alcohol liver disease, the hepatitis or infectious hepatitis B or C, and the last was, what are your differential, Dr. Hene?
My differentials are the first one was very sharp bleeding.
Yeah,
The other
resale
one
due
was
to chronic liver disease because of alcohol.
alcoholic, yes.
Or what
Then
else?
I'll now go to non-varitional, like the bleeding peptic ulcer disease.
Peptic ulcer, okay, can give
Because of,
you
yeah. Then I'll now talk about the
Mallory's. Yes, Mallory's. You give
Malawites.
also
Yeah.
Mallory's. Perfect.
I
Okay.
also mentioned
Yeah,
recent gastritis from
okay,
NC.
perfect. You can add just to them the hepatitis, either B or C, and chronic liver disease because of the infection. Okay, if the patient lost weight, what you can add to your differential? Lost weight and appetite, cachexia.
If he has lost weight, I'll go with malignancy will come into place. ACC, hepatocellular carcinoma.
Perfect, yes. So it can be one of the differential again. Then the next for the clinical judgment. Whenever you have acute presentation, please ABCD approach in top of your management. Okay? Dr. Ibo mentioned you, but I think you forgot to mention it.
He didn't ask me to manage this patient, Dr. Bazim. He didn't ask me to manage the patient. He just said, which medication will you give? He was just asking me more like a direct question to answer. He didn't ask me
Okay.
to manage this patient. He didn't ask me.
As
Because in my book, yeah, I wrote all those things down in my book when
okay,
when I saw the vital
it's okay.
signs.
It's
I
okay,
wrote all
Dr.
those things
Rina.
down.
I don't want you to be more nervous. The problem and the issue here and the point here is to learn from mistakes. So I don't want to just to have defend because he didn't ask, he didn't do. Whenever he is asking, put in your plan that I would like to start with this approach whenever I have patient with acute presentation. Again, the mistakes here, much better than the mistakes in the exam. So please calm down. No need to be defender. Just learn from the mistake and the point I want you to understand. Okay. Even the question was not that much proper. Just learn the point from any patient having presentation as acute with loss of blood, not only in this upper GI, even epistaxis, melena, a lot of melena, and hypotension patient, I should admit him with ABCDE approach. Just remember this point, okay?
Okay, Dr. Baza.
Oh, okay. Then the next point for concern, you address the whole concern, the welfare as well was perfect. Any question, Dr. Henry?
No, not at all. Not at all.
Okay. What you expect in the blood sugar in this patient? The reading of blood sugar.
It could be high, it could be normal, it could be low.
And
The
if
reason
this
why it could be
patient
high
is
because
advanced,
the
if
reason why
he's
it is the
okay,
reason
if he's advanced cirrhotic liver disease, what do you
yeah,
expect?
if each patient is not a non-diabetic patient, like in this patient is a non-diabetic patient who is not compliant with the medication with high HbA1c have an issue, it may be normal or high. But if it's not a non-diabetic patient or it's a non-diabetic patient with control of his medication or control of the diabetes, I expect to have a low BP. And also if it is a malignancy,
Blood sugar.
yeah, blood sugar, because of the blood sugar, if the patient is a diabetic patient that is not regular on medication, like in this patient, it will be either high or normal. Then if it is well controlled, the blood sugar may be low because of the advanced case. And also, if the patient is having cancer malignancy as a complication of the LCC, one of the extra manifestations of malignancy could be either hypercalcemia or hypocalcemia. They have different mechanisms by which they result to that. But in this case, I will expect a normal or raised blood sugar in this patient because of the poorly controlled diabetes mellitus.
Okay. The question another way. If this patient is diabetes type, whatever the type, he's diabetic and he is on insulin for a long time, what you expect the dose of his insulin and the requirement of his insulin?
Yeah, it will be reduced because of the
Yes, okay.
to
This is my
reduce.
question. So it will be reduced. Even sometimes the patient will be hypoglycemic. Some
Yes.
patients, sometimes you might administer dextrose, whatever the percent, either 10% or 20% because of the hypoglycemia. Okay, again, those are the lessons to learn from those scenarios, not to be nervous, just learn the points and try to avoid these mistakes in next sessions or even the exam. You will remember these mistakes and you will not repeat it. This is our aim, okay? Thank you, Dr. Henry and Dr. Ibu. Now, before going to the next scenario, I want Dr. Henry to post the scenario for Dr. Ibu. Then I will open the discussion.
Okay. I've sent it to you, Dr. Bazin, to your
Yeah, okay, sure. Yes, of course, cross matching and ABO grouping, very important before doing anything or just from the sampling. First sample, you can do venous blood gas as bedside test. It will show you the hemoglobin level. That time you can even include in your investigation cross matching and ABO grouping. Plus, consider the acute coagulation profile. I mentioned it just to be ready whenever you have, and this is expected for chronic liver disease, the INR could be higher. So you have to be ready. And in case of, you can even consider the vitamin K. Dr. Ibu, the scenario in the chat box, patient name is Sarah Bennett, the age 41, complaining of vision, blaring of vision. 2 minutes, then we'll start. Quickly, I will try to read the comment. Chronic hepatitis B and C, yes, exactly, Dr. Ola. Here, shrunk liver or hepatomegaly. It depends on the case, either early stage or late stage. The late stage will be cirrhotic and shrunken. Early stage, it might be enlarged liver. So the next, Dr. Ibu, slightly enlarged and carcinoid. Oh, yes. So this is the answer. Thank you. Blood grouping, matching included in investigation. Absolutely right. You have to consider it, as I mentioned. Diabetes on the risk factor for hepatocellular carcinoma. Okay. One more differential you can consider whenever you have diabetes type 1 in young patient and he has chronic liver disease. What other, Dr. Henry, again, the question for you. Type 1 diabetes, patient is having chronic liver disease. What you expect or you can add to your differential? What could be other differential?
Yeah, like I said, metabolic syndrome, that is non-alcoholic fatty liver disease, could explain that because of the diabetes is one of the criteria for, and if he has hypertension, also have diabetes, also got metabolic, a non-alcoholic fatty liver disease, can cause the chronic liver disease, can be a cause of the chronic liver disease in this
Okay,
because of the diabetes.
what else?
Then also because of the diabetes too, and then this is type
Type
1.
1, type 1
Yeah,
diabetes. Type
if
1
it's type 1,
diabetes.
look at autoimmune hepatitis too, because of the autoimmune nature. Think of autoimmune hepatitis.
That's
As
perfect.
because
Okay.
of the
Autoimmune, primary cholangitis, primary serial cholangitis, or primary sclerosing cholangitis. All of them are autoimmune conditions. Okay. Now the time for question. Any question from anyone? Or any comment, not only question. Anyone want to add any question or comment, please?
Regarding hemochromatosis and Wilson disease is
Perfect. Yes. Perfect. With diabetes, of course you can add it. Yes. But when you add it, Dr. Hosni, because you asked this, hemochromatosis, when you consider it strongly,
if there is tanning of skin,
perfect, and
if there is any neurological involvement of the brain.
okay, this is by examination. What about history? Anything in the history can give you a clue?
Clue for
Yeah,
Wilson or for hemochromatosis?
For hemochromatosis.
Maybe repeated blood transfusion.
Even for Wilson, by the way, it was or it's one of the shared criteria in Wilson and hemochromatosis.
family
Any
history.
tremors, fine tremors, or
No. I just posted a short video regarding this history in particular. If you hear the video, did you hear the last video I uploaded last weekend?
Family
Yesterday.
history.
Yes.
no.
Family history, exactly. If you have positive family history, you might add both of them to the differential. But by the way, you will add to the Wilson some neurological manifestation. And hemochromatosis, as you said, you can add some skin manifestation. But family history in both will be positive. So let's talk about the mode of inheritance in hemochromatosis and Wilson. What are the mode of inheritance?
Autosomal recessive.
Yes, both of them. Perfect. Thank you also, Dr. Aya. Any other question?
Cystic fibrosis also, or
cystic fibrosis, why? You will add it? Why it could affect the liver? You can add another differential if you want to talk about some collagen disease, or you can say
alpha-1 antitrypsin also.
Exactly, yes. This is the one I want you to mention. So alpha-1 antitrypsin can be there as a differential for cirrhotic liver. Although it's very rare condition in cases, but still it's one of the disease can affect the liver. Okay, of course, along with the emphysema to the lung and the spirit failure. But cystic fibrosis, I doubt it can affect the liver. I am not sure.
Okay, thank you.
Affect the pancreas, but it doesn't affect the liver. Okay.
Okay, thank you, Dr. Bass.
Most welcome, Dr. Hasni. Now, any question before moving to next scenario? Dr. Ebo, are you ready?
Yeah, yes, sir.
Okay. Reset the timer. Here you go.
Hello,
Hi, doctor.
this is Dr. Ahmed here. Am I talking to Miss Sarah Bennett, 41-year-old?
Yes, doctor.
Okay. How do you want me to call you?
Yeah, Sarah is okay, doctor.
Okay. Miss Sarah, I would like to discuss your health condition with you. I will try to note down a few things that will be confidential, then examine you, and we will reach some conclusion. Is it okay for you?
Okay, doctor.
Okay. Your GP note says, Miss Sarah, that you are complaining of blurring of vision. Can you put it into your own words?
Yeah, doctor, for a very long time now, I can no longer see properly. My eyes keep going blurred, doctor.
That must be concerning. We are here to support you, Miss Sarah, rest assured.
Thank you.
Is it the first time that you have noticed your
Yes,
Oh.
doctor. It's the first time. I've not had similar thing before, It's the
Mhm.
first time.
And is it sudden or gradual?
Yeah, doctor, it's gradual.
Since when are you experiencing this?
For the past 8 months now, doctor.
8 months now. And you said it's gradual, right?
Yeah, it goes, it comes, it goes, doctor.
Okay. So it's intermittent, not staying there all the time.
Yes, doctor.
Okay. Can you tell me at what time you have more of problem with the visual blurring?
Doctor, it can
I mean,
come at
is it
any
in the
time
more
because
in the morning or more in the
it can
evening?
sometimes it comes in the morning, sometimes it comes in the evening. Because of my profession, I works in the morning. Sometimes I feel I stay at home in the evening. So sometimes before the day goes by, it gets worse. And that's
Okay.
yeah, doctor.
So is it concerned to your activity? I mean,
Yes,
what?
it does. It does affect me. I can't read my papers any longer. I can't mark
Mhm,
the script of my students any longer. It's annoying, doctor.
mhm.
Mm.
That must be worrying you. We assure your full support and we'll try to seek help of the occupational therapist team. Okay.
Thank you very much,
Now,
doctor.
do you feel like you are bumping into objects when you are moving?
Yeah, I've had that about 3 times now when I'm driving. Yeah, when I was coming back from my place of work, I've had that, doctor. Yeah,
Okay. And what do you do, Miss Sarah?
I'm a teacher. I'm a school teacher.
That must be worrying you. And for sake of your safety and the safety of those around you, I would really suggest, and it's highly advisable that you pause driving till the time
Okay,
we
doctor.
come up with a solution for this.
Okay, doctor.
Okay. And I mean, is it painful?
No. I don't feel any pain in my eyes, no, doctor.
Okay. Do you feel like your eyes are prominent? Do you feel like people tell you that your eyes are getting more prominent?
No prominent. No, not at all.
Do you feel like they are drying up?
Drying up. No, not at all. I didn't know.
Mhm. Okay. And do you feel any itchy or redness?
No,
Okay. Do you have any any headache associated with it?
no, doctor.
Okay. Any loss of consciousness you may have experienced?
No, doctor.
Okay. Any funny sensation anywhere on your body, like tingling, numbness?
No, doctor.
Okay. Did you experience any shakiness of your body, any part of your body?
No, doctor.
Racing and pacing of heart, Sarah?
No, doctor.
Any problem with the breathing?
Yes, sometimes occasionally I have this shortness of breath, doctor.
Uh-huh. And when is it more? Is it the time of sitting, resting, or moving?
Yeah, it's when I just come back when I come back from work, I do have when I'm climbing upstairs after coming back from work, I do have this occasional shortness of breath.
Is it related to position? I mean, when you lie down, it increases. When you're sitting up, it's okay. Is it like that?
No, it doesn't. It doesn't relate to position.
Mhm. And do you feel like short of breath when you're sleeping at night?
I've never, no, I've never, no. That's all.
Okay. Okay. Any problem with your, eating or swallowing?
Yes, I do some. I sometimes, find it difficult to swallow. I do have some occasional difficulty in swallowing, doctor.
And when do you experience it more?
Pardon?
When do you experiencing it? When do you experience the problem more? Any
Yeah,
patterns?
especially when I'm eating, when I'm almost done eating, I experience it, doctor.
When you're starting to eat, you feel the problem more, or when you have taken it through the mouth, then you feel problem in your chest?
Yes, when I started eating, I don't feel it, but towards the end of my meal, I start feeling it. Sometimes I sometimes bring out the food I ate because of that.
Okay. So you had any change in your weight? Recent changes?
No, doctor.
Okay. Any sweating, night sweats?
Nice sweats.
Yeah.
Not at all, doctor. I've not noticed that.
Okay. Any intolerance to hot or cold environment?
I do have that, but no, not anymore.
Okay. Any medical condition that you have?
Yes, doctor. I was diagnosed of autoimmune hypothyroidism. When I was at the age of 35 years,
Okay.
and
And how are
and
you putting
also
up? Are you taking medicine for it?
yes. I was placed on some medication, doctor. I've been
And how
taking
is your control?
Yeah, my control. Well, so far it has been great because I no longer have that initial feeling tired. I no longer feel that you know I cannot tolerate cold unlike before.
Okay. Okay. Any other health problem that you would like
Yes,
to share?
yes, I also have this anxiety problem, doctor.
Okay. Are you taking
Mm.
anything for it?
Yes, I'm taking some medication, doctor.
Would you like to name them?
Yes, doctor. I took currently you mean on my medication or the one for the I'm taking levothyroxine. I'm also taking amlodipine. But recently I was changed to carvedilol because of my chest feel because I was later diagnosed to have angina. So the amlodipine was not really fulfilling. I added um, what do you call it? There's one that says a beta blocker, so they added it. I've forgotten the carvedilol. They say they added. I think so. Yeah.
Okay. So since when you are taking this carvedilol?
Yeah, for the past 1 year now, I've been taking it, doctor.
Past 1 year.
Mm,
Okay.
with the
And how do
amlodipine
you
for that.
feel now after you're taking carvedilol? How do you feel afterwards?
Yeah, I no longer have that the chest pain I do have
Fine.
occasionally because of the angina and the anxiety they diagnosed me.
Okay. Do you smoke?
Yes, I smoke.
How many
I was told to stop smoking, but doctor, it's very difficult for me to do that. I've been trying, but
Have you stopped it now?
no, I've not. To be candid, I've not stopped. I've been managed, but I've not.
You still taking smoking?
Yes,
You are still taking cigarette?
I'm still smoking.
It's
Yes,
highly advisable, Ms. Sara, that you stop smoking because we need to go through few rounds of tests to come to come to diagnosis what you are having. So for the time being, you need to stop it. If you need any help, we can provide you with smoke cessation
doctor,
service.
I need help because I was told last time I was diagnosed of angina. They told me to stop smoking, but I've been
Yes,
trying. I need help. Please help
we
me.
can help you, Ms. Sara. We can assure you we have dedicated
Okay.
smoke cessation service.
Thank you,
And
doctor.
do you consume alcohol?
Alcohol?
Yes.
No, not at all. Not at all. I've done with it.
And you told me about you work as a teacher. Has been back
Yes.
to your work. And how do you, are you having a stable partner?
Yes, I do. I have a stable partner, doctor.
Okay. And do you have any casual partner?
No. Just me and my partner.
Okay.
Just
Okay.
one.
Uh, okay. And how are your, okay, may I ask you about some personal questions? How are your periods? Any problem with that?
No, my period has been good, but recently I no longer see it that often like before.
Mm-hmm.
Mm.
Okay. Do you have any kids?
Yes, I do. I have two kids.
Okay. And what are the ages of the two kids?
One of them is 10 years. The other one is 4 years.
Mhm. And okay. 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 Any rash or anywhere on your body, sir?
No rash, doctor.
Any joint pain anywhere?
No, doctor.
Okay. How's your water works and bowel works? Are they normal?
My water works is normal. My water work is normal.
Mhm. Okay. So I will try to examine you now.
Okay, doctor.
I will try to look at your hands first. First, a general outlook of your the whole appearance. And then I will try to move to your hands. I will try to look at your hands. Try to look at the nails. Try to look at the texture of the hands, whether or not they're dry or sweaty or
The answer are good. Nothing in the hands.
okay. And then I will try to check the pulse.
The pulse. Okay, the pulse is normal.
Okay. Meanwhile, I will see the palmar area as well, the palmar crease.
Yeah, the palm is normal. The crease are normal.
Okay. Then I'll try to move up, looking at any scars or any
No scars.
marks or any.
Nothing.
Okay. Then I offer BP.
BP is normal.
Okay. And lying and standing BP, is it normal?
Yes, line and standing normal.
Okay. Then I will try to look at the face, mouth.
Okay, the mouth is normal. The face, he has I've sent the image to you. Okay, let me send it to the group. So to the group. 1 minute. The image. Yeah,
The image.
yeah, it's at the group. I sent it to the group. The image is at the group.
Okay.
You've seen it? Have you seen it? That's the face.
I haven't seen it.
You've not seen it?
No.
It's at the Dr. Basim's group, the WhatsApp group.
Yeah.
Okay, I will share it. I will add 1 more minute for you, okay? The picture now will be shared in the
Okay.
chat box.
And
Here it is.
yeah. So, and then now I will try to look at the eyes, movement of eyes. I will try to do the ocular movement. I mean, by making an H.
H. Okay. When you make an H, you will see there's the right eye. It's there's difficulty in abducting the right eye.
Okay. Right.
Then
Abduction.
Then the left eye have difficulty in raising the left eye up too.
Okay.
Mm.
So I mean, to us, right is on the. I mean, as we look at the picture, it's on the left. Right. You mean to say that right eye is having a problem, and left
Yes,
too.
at the left, you could not lift the left eye up very well for the left, while the right could not abduct. Sorry, there's limited abduction. It can abduct, but not completely.
Okay. Okay. So, okay. The right has got problem with abduction and left is unable to. And the left can abduct?
Yes.
I'll try to check the pupillary reflex as well.
Reflex. Okay, when you check the pupillary reflex, direct reflex, normal.
Okay. Direct and consensual normal.
Consensual, normal too, yeah, normal, sorry.
Okay. Perfect. And I will briefly check accommodation as well.
Accommodation, normal.
Okay. I will offer fundoscopy.
Fundoscopy,
Yeah.
they'll say, okay, skip. Examiner will say skip.
Okay. Then
2
I
minutes
will.
left.
Okay. Then I will ask to do the pronator drift.
Monitor GIF, yeah, it did it. Yeah, normal.
Okay. And then I will try to check apex.
Apex, you check the apex. Apex is at the 5th left intercostal space, mid clavicular line.
Okay, it's normal. So yeah, and then I will put the stent on the apical areas, trying to check the chest and carotid buoy. I will try to check the carotid buoy as well.
No carotid buoy. No, the apex is normal. S sound, S1, S2, no normal.
Meanwhile, I will try to look at the neck as well, whether or not there is any growth or any enlargement in the neck.
Yes, in the neck, there's no swelling in the neck.
Yeah.
Mm.
Then I will ask you to please, while looking up at my finger,
Yes,
count to 1, 2, 3. I mean, like 1, 2, 3, 4, 5, 6, 7, 8, 9. I'm up till 20.
up to 20.
Keep looking at my finger when I'm holding
Okay.
it, and keep counting till 20.
Okay. When I count to 20, there's the two eyes fell down.
Okay.
Both eyes.
And then I will try to check the pressing on one curtain that is affected, one eyelid, and try to look at the other eyelid, checking for the curtain sign you make.
The cutting sign.
Yeah.
Okay. Cutting is absent.
Okay.
Which of the eye checking for the cutting sign? Is it the two eyes or one eye?
I will put on the affected side, on the two eyes.
What will you do how do you elicit the cutting sign, doctor?
I will just press on the lid of the eye that is affected.
Mm-hmm.
No, I will press the other eye up, the right eye up. Hold it.
You press the eye up.
Yeah.
You
Hold the
touch
lid
the eye.
up.
You want to do it in the exam?
Sorry.
You want to do it in the exam? Do you want to do it in the exam?
I will offer.
Skip.
Okay. Then I will try to check the proximal muscle strength. I will ask you to do the chicken wings movement repeatedly.
What do you mean? Pardon?
I will ask you to do the chicken wing movement on the arms repeatedly.
The two arms or one arm?
Both
arms. Okay. Well, when you do it, there's weakness in both hands.
Okay. So yeah, and that's it. So what are your concerns, Ms. Sarah?
Doctor, what is wrong with me, doctor? What do I have?
Well, Ms. Sarah, from what I have collected from you in the shape of history, after examining you, it is one of a condition. I have come to conclusion that it may be one of a condition that we call autoimmune condition. Don't get bothered or rattled by the words. It's a condition in which the defense system of your body starts attacking your own tissues or your own cells. In your case, what happens, it's called, most probably, it may be myasthenia gravis. And in this case, what happens is the nerve signals are unable to pass properly from one end to other end. And thus there is weakness in conduction of the nerve signals through the cables, and thus after a little while, the muscles are unable, or the conduction is unable to pass, and the muscles are weakened as a result. So in your case, that's the problem. Yeah. Any other concerns?
Thank you so much. Hope it is treatable, doctor.
Sorry?
Hope it's curable. Is it curable?
It's not curable. It is controllable. It is manageable with right medications, and with avoiding certain medications, which may aggravate it, which in your case has got aggravated because of the medication that have used for heart rate alone. The one medication that doctor had prescribed for you has aggravated this condition.
Doctor, whenever the time is near to finish, try to be more short, very concise. Time is up already, but I added some minutes. just to finish the consent. But in the consent, don't talk in details. Just give him very short answer, okay? Clear? Dr. Ibo?
Yes, sir.
Okay, time is up. Examiner question.
Thank you, doctor. How will you present your positive findings? Present your patient, positive findings for the patient.
Sarah Bennett, a 41-year-old, she came with the complaints of a problem with blurring of vision for the past 8 months, and it was of intermittent nature, and it was painless, and it was of gradual onset. She also complained of having shortness of breath and problem with the swallowing as well. She is already taking medications for her known medical conditions like hypothyroidism and hypertension as well. She's taking amlodipine for it. For her just inguinal symptoms, she is taking carvedilol. So on examination, so on examination, I couldn't elicit anything significant other than the fatigability. I could see illicit fatigability in her able to put it long. Yeah. On examination, I could see that her movements or her actions were fatigable, and that's equated to myasthenia gravis, a condition we call myasthenia gravis. She was unable to talk in one flow, counted to 20, and there was a proximal muscle weakness. And yes, I will put it to myasthenia gravis.
Okay, so what's our differential diagnosis?
Differential can be Lambert-Eaton myasthenic syndrome, but in that case, repeated movement will increase the strength of the repetition of the action or repetition of the steps will increase the action. I mean, increase the output of the activity.
Okay, any other differential?
And I can also put it to some conditions like oculopharyngeal dystrophies, in which cases the eye muscles, or the eyelids and the eye muscles are weakened. But
all right, how will you investigate your patient, doctor?
Yeah, in this case, we'll try to check antibodies, anti-musk, anti-acetylcholine receptor antibodies. We can do ice pack test on the bedside that will allow us to determine whether or not it's myasthenia gravis. We can also do antibodies. We'll draw blood samples, checking antibodies for thyroid as well. We can also do, we can also do. Yeah, that's what we are going to do.
Okay, so how will you manage this patient?
We'll try to involve multidisciplinary team, involving neurologist and endocrinologist and ophthalmologist. They will try to run a few tests and do a scan as well to check whether or not it's any problem inside the eye globe, and they will also try to do EMG. In that they will find decremental response, and then we can provide, if it's myasthenia gravis, they can provide medication like pyridostigmine. They can also do CT scan to rule out thymoma.
So you mentioned EMG, decremental response in EMG. Is that what you said?
Yes.
Decremental response in EMG. Okay, good. All right. Are you done with your management, Dr. Ebu?
Management is like stopping smoking. That's very important, and then the patient can be provided with pyridostigmine.
Okay. Okay. If assuming you after providing the pyridostigmine, patient did not improve, do you have any other condition, any other treatment option you should have done in this patient?
You mean to say plasmapheresis?
After giving pyridostigmine, patient did not improve or probably improve for a while, and later symptoms persist. Any other treatment plan you want to do? Hello, are you there?
Yeah, I mean, we can give steroids as well.
Okay, you give steroid and patient. Okay, outside steroid, is there another treatment plan you want to do outside steroid?
Yeah, and then if these medicines if they are unable to work, we can go for plasmapheresis. Filtering out antibodies.
Is there a role for plasma sparing medication? Sorry, steroid sparing medication. Steroid sparing medication.
Yes, we cannot put steroid for a longer time, so we can give medications like azathioprine.
Okay. So if you want to give them those medications, is there any blood test you may need to do before commencing on those medications?
For azathioprine,
Yes.
we can do a TPMT, if I'm not mistaken. We do that.
Okay. Okay. Is there a role for surgery in this patient?
Yeah, in case thymus removal. If that's enlarged, we have to remove the yani. If we have through
Okay.
CT scan, if we find a thymoma, we should remove thymus.
Okay. Okay. All right. Okay. Well done, Dr. Ebu. Well done. That's good.
I have one question, Dr. Henry, please.
Okay.
In the acute flare-up, Dr. Ebu, what you consider?
In acute flare, we will go with the plasmapheresis.
Okay, perfect. But again, for any crisis or any acute presentation, what you should start with?
For any crisis, what you would start?
For any
Steroid?
crisis with acute presentation, you will go with the steroid medication first, straight away? Patient
No,
presents to you with myasthenic crisis. How you can... Yeah.
Yeah, for that we will do IVIG, like intravenous immunoglobulins.
Again, you didn't get the question. Patient presents with you with history of myasthenia gravis, and he now presents with myasthenic crisis.
Yeah, that means we have to start the airway breathing and circulation, like ABCD protocol.
Exactly. This is what I want you to mention. Okay.
Yeah.
In the term of airway, what you expect?
We have to do the bedside FVC.
Perfect.
In this case.
Okay.
Make sure that
and in terms of breathing problem, what do you expect?
I mean, he can have a respiratory issue.
Yes, exactly. What type of respiratory failure he might have?
Type 1.
Yes, hypoxic initially, then later on,
yes,
he will be...
It will be type 2. First, it will be type 1, and it can be type 2.
Yeah, hypoventilation, okay? So what you can consider for those patients if he presents with you with respiratory failure?
Then we have to seek help of ventilation.
Exactly. So we might consider intubation, RT involvement.
Exactly.
And yeah, continue.
There's a criteria. I mean, like FVC should, if it's less than 20 ml,
yes,
so go for intubation.
Less than 20 should be in ICU. Less than 15 could be intubated. Okay, to be monitored. And how you can monitor, as you mentioned?
Spirometry, bedside.
Yeah, forced volume capacity. Right?
Yeah. What is it, Dr. Basim, less than 20? I didn't hear.
The minute ventilation. Less than 20 ml per kg, consider critical, and he should be monitored in ICU. Less than 15, you can even intubate the patient. Forced volume capacity. Okay?
Forced vital capacity.
Yeah, forced vital capacity. Forced vital capacity, FVC. And by the way, it's the same for Guillain-Barré or any patient has respiratory affection, respiratory muscle affection. Forced vital capacity. Clear? Okay, thank you, Dr. Iwo. Dr. Henry, you can comment now, Dr. Henry. Sorry for interruption.
Yeah, it's okay. Thank you very much, Dr. Muazzam. That was a good one. You did very well. You were able to get the diagnosis. You know, let me go straight to some of the comments. Let me start from back up from the diagnosis upwards, because in this case, the case of complex ophthalmoplegia, that is what it was stated in the marking scheme, complex ophthalmoplegia. So the examiner is wanting to mention that word, complex ophthalmoplegia, and likely due to myasthenia gravis in this case, because he has evidence of both ocular myasthenia gravis, bulbar myasthenia gravis, and the center. He also has evidence of, generalized myasthenia gravis. So it's due to generalized myasthenia gravis, causing the complex ophthalmoplegia. Differential diagnosis, you mentioned LEM. LEMS typically does not really cause complex ophthalmoplegia, but well, you may want to consider, because since you mentioned myasthenia gravis, this patient has features of has a thyroid disease previously. I would have expected you to mention thyroid eye disease in this case. He's taking he has autoimmune hypothyroidism. He's taking medication. He no longer have the symptoms. He didn't ask him when was the last time he went for follow up. The last time he did a thyroid function test, to check if it was very high. Probably it's possible that the patient has started treating towards hyperthyroidism, in future. So these are the things you would have done for this patient. So one of the differential diagnoses here is thyroid eye disease, because of he has history of hypothyroidism and he's on treatment. So you have to, and also he's still smoking. I know that smoking can sometimes exacerbate thyroid problem.
Yes, smoking.
Yeah, so you may also consider as a differential diagnosis a thyroid eye disease. Then also, like, it's a good differential diagnosis that you want to mention too. Like you mentioned, I think you mentioned, I heard you saying oculopharyngeal muscular dystrophy.
Yeah.
Yeah, beautiful. It's a good differential diagnosis. However, you did not ask for family history.
Yeah, I didn't
So
ask
family history, as for family history would have given you a clue, because family history will further suggest if he has evidence of that in the family. Yes, you can go with oculopharyngeal muscular dystrophy, because family history they present with ptosis, dysphagia like in this patient, plasma weakness like in this patient, although it is not fatigable in oculopharyngeal muscular dystrophy, but they also have plasma weakness and they have family history. So it has family history that made you, I also consider it as my differential diagnosis here, but should have bring it up, as your because if there's no family, but you didn't ask family history in your history, that's why I did not get that history. And then also see part of the management, other differential diagnosis that could also be, multiple sclerosis, but which is very unlike brainstem disorder. But it's like in this case, because it's a demyelinating problem, and sometimes he has problem with vision. You've tried to rule out the if it's a pain, you ask of pain to rule out optic neuritis, which is beautiful. You also ask of evidence of previous eye problem, which is wonderful. Patient does not have, and then issue of weakness, and we also ask you rule those ones out too. But it's unlikely, but just to consider it as maybe your fourth or fifth differential diagnosis because of the eye, the evidence of failure, some eye problem that the patient has, and then with the eye feature too, and then the plasma weakness that the patient has. So then other things, I think these are the major differential diagnoses here. Then for the investigation you mentioned EMG, decremental response on EMG, and I ask you again, you still mention it. EMG does not show decremental response. It is nerve conduction study.
Yeah, nerve conduction study, true.
Not EMG. EMG you want to do, especially the single fiber EMG. If you're doing, you may need to, what they call jitters. That's what you see on EMG.
Yeah,
Nerve conduction study, you see a decremental response on nerve conduction study. So that's why I was asking you again to be sure if truly you really, got then the issue also, he didn't mention CT or chest X-ray in this patient.
Okay. Yes.
This patient has difficulty, he has shortness of breath. You are thinking of myasthenia gravis. Could you be having tymoma that's causing shortness of breath in this patient? Could it be due to the weakness of the diaphragm that's making this patient have shortness? Because the patient has shortness of breath. He has it in history. He did not examine the chest in this patient. You will examine the heart. You will examine the heart. examine the murmur, but he did not check the chest. He didn't do chest expansion. Patient that is presented with shortness of breath should have done chest expansion. Then and also investigating that line to rule out thymoma as a differential as a cause of shortness of breath, or also due to diaphragm weakness due to the myasthenic. Those are causes of shortness of breath in patients with myasthenic gravis. So those that was missed out in your management plan, also in your investigation, and then in your examination. And also, you did not examine you are thinking of also you didn't do other, what do you call it, the mouth. You didn't examine the mouth. Patient says not having problem swallowing. You didn't check the tongue. You didn't check the mouth. It didn't involve salt, speech therapy. It didn't involve, because you also have having a nasal speech, because of, when he talks, because of the bubble manifestation. He has bubble symptoms, difficulty in swallowing, speech problem, and swallowing, and what do you call it? Yeah, chewing, speech, and then swallowing problem. So you should have examined the cranial nerve completely in this case. Cranial nerve 9, 10, and 12. Very, very important in this case. That was missed out too in this particular case. And also in all case of when the suspected myasthenia gravis because of the bubble symptoms. And then also for the, okay, at least you asked do you ask me of neck swelling in the history? Neck swelling. Patient that has thyroid. I told you I have thyroid disease. He didn't ask about if I have any neck swelling. Neck swelling. On the examination, you check for the neck, which was good, but in the history, it's not also going into detail to ask about the neck, if there's any neck swelling. You only ask about codeine tolerance. Yes, and I told you that I have that previously, but I don't have it anymore. But you did not ask of neck swelling, anterior neck swelling, which can be also important in this particular patient. Too, you ask issue of proptosis, which is beautiful, just to rule out thyroid eye disease. Also, you also advised me of driving, which is good, beautiful. And then management, I think Dr. Bazim have discussed the management. Also, surgery is very key in this management. We have to it's possible that this patient is having thymoma. We need to remove the thymic mass.
Yes.
So surgery, especially the patient that is suspected shortness of breath, we need to do CT scan. If there's evidence of there's evidence of thymoma, we need to do a surgery, because it has been shown the removal of the thymoma has tends to have a good prognosis after removal of the thymoma. So these are some other things that I think I knew that I noticed down in your case. You also advised to stop the medication, which is good. I think you said you're going to invite other team. Like in this case, you may need to invite the cardiologist too, because they are the one that are also giving the other medication. If they are stopping the beta blocker, they'll give him something else that also do with it. Yeah, and I think which other thing to, I think, let me see. I think these are the things I really jotted down. Otherwise, it was a good one. Well done, Dr. Ebu.
I was unable to actually explain, in the during concerns.
It's okay.
My
You
senior
did very well.
gravis.
Okay, if you repeat it, Dr. Ibu, now, how you can repeat it? How you can explain
I
the
would say,
myasthenia gravis?
I would say it's a autoimmune condition. Don't get bothered by the word. It means the defense system of your body starts attacking your own muscle and tissues,
Perfect.
and thus the conduction of transmitters or message from the muscle to the nerve to the muscle doesn't get carried properly, so it leads to weakness.
Okay. This is fair enough. No need to be more detailed in the explanation, okay? Just simple words and one sentence. You have a lot of concern. You will not have one concern only. That's why it was on the spot the advice, don't talk more if you have already the time was up. So you are rushing to finish the concern after the concern. No need to give the details. What I have, I'm so sorry, you have a condition called myasthenia gravis. Don't bother about the name. It's one of the defense system disease that attacking the gland in your chest, and instead of attacking the body. You have other concern? Yes, doctor. Is it controllable? I appreciate your worry. Yes, one of the medication can be controlled with some medication. Sometimes need to do other surgery if there is indication. Any other concern? Yes, doctor. Will I have cancer? Will I have problem with my breathing? yeah, sorry to feel that. I can say that you might have some life-threatening condition if you don't have the control of this, if your gland. Any other concern? And so on. Okay, don't give a lot of details. And if you don't know the answer, you can just give him opinion from the senior, or I will ask my my consultant. But to speak a lot to answer one concern, you will lose the other concerns.
Yes.
Remember it. And the concern has some marks. If you didn't fulfill it in every station, you might fail. I know some of the candidates who failed all exam because of one mark in the concern. So remember, concern to be shortly answered. He doesn't need a lot of details, a lot of medications, just simple words and one sentence. That's it. Okay. So regarding the concern, I already advised on the spot. Let's go for the examination. How many system here affected to examine? Dr. Ib. The eye,
The eye
exactly.
and the neck need to be examined because he mentioned about
Okay.
thyroid.
And also you
And
mentioned about dysphagia. Okay.
yes,
And
this way
and chest.
and chest.
Okay. There is some characteristic examination for myasthenia gravis. What are they? And you did them, most of them.
Fatigability.
Okay. How many types of myasthenia you know?
The general ocular myasthenia gravis and the general myasthenia gravis.
Perfect. How to differentiate between both? By one test.
The antibody test.
No, no. The same test, but you will use it in different organ. The fatigability test. Still,
Fatigability test. Yes,
yeah,
fatigability.
exactly. So you will do it in the eye, you will do it in the arm. By the way, when you do the fatigability test, you will do one arm adduction, abduction, one adduction, abduction, and you will ask the patient to adduct against resistance,
Okay.
right? The arm with frequent abduction and adduction, it will be very weak to resistance, and the other one will be little bit strong, right?
Okay. Yes, sir.
In the eye, the same. You will count here and there. You will see which eye or both of them will be either the eyelid will be down or the eye itself. It will be the eyeball will be moved also down. So this is and the tone. The tone also will be reduced by the counting himself. The patient he will count. Who will count? And at the same time, looking up, you will finish two tests in one step. The
Okay.
speech and the fatigability, right?
Fatigability. Yes.
So both of them, you have to do it in one step. Can you count, please, from 1 to 20 and look up for me? Look at my finger and count it. He will look and he will count. At the same time, the tone will be reduced or it will be switched to nasal tone and the eye will be dropping down. You finish one, as I said, two examination by one step. This eye
Can we
must
ask him to do the chicken wings beating at the same time, abduction, adduction, while he's looking up and counting 1 to 20?
no, 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 no. It's too much.
Too much for
Yeah, he cannot concentrate on all of them in same time. So ask as you start from peripheral, finish the fatigability for the arm first, then go to the eye and face to do it as second step for ocular myasthenia. So you start from the arm, then the eye. Okay, very important step to do percussion on the sternum for retrosternal dullness. If
Yes.
there is thyroid or goiter, do the steps of thyroid inspection, palpation, percussion, auscultation. Okay, this is for the thyroid whenever the thyroid is there. The chest, as it was involved, you can do palpation on the chest for the expansion. It will be maybe limited. Okay,
Yes.
plus of course auscultation and percussion if you have time. But the most important, the expansion. It will be a little bit limited. This is regarding the examination, which is as concise one. If you have to do the details examination for the vision, you have to do as we do AFRO, Afro H shape. Afro H shape. But to be more concise, you can do, as I said, the fatigability test. It will be more conclusive and specific. But if you want to show the examiner that I would like to examine everything in the eye, the acuity, the fields, although it will be normal. The H shape, it might be conclusive for ophthalmoplegia. The patient will either will have pain or he will have double vision. But the fatigability is a must and it's crucial to be done. So this is regarding physical examination. Identify the signs. We finish both of them. Then the clinical communication. I believe you did good, better than the previous time. And the most important question here, the previous attack, on and off, and what you mean by vision problem. This complaint, along with fatigability, you have to ask, what do you mean by fatigability? What do you mean by weakness? What do you mean by vision problem? And according to his sentence and description, you will know what he's talking about. What you mean by vision problem? Doctor, I see two. This is the diplopia. Continue the approach of the diplopia. Doctor, I see very weak at night. So this is night blindness. I cannot see well at the periphery. If he's helpful, he will tell you in details what he has. Sometimes he wait for you to ask individual question. What about the color vision? What about the night vision? Do you see double? There is any pain? Any redness in the eyes? Okay, all of these questions you have to remember. Any double, any pain, any redness, any discharge from eyes? Okay, all this question makes sense. Unless he started to mention it. This is regarding the complaint. The relevant system here will be CNS questions. Hearing problem, any balance problem, any headache, any weakness in your body. Okay. And the constitution as you did. Here you might have positive constitutional system as weakness. Yes, I feel weakness. Immediately ask any specific time for the weakness. Yes, doctor, I have it at the evening or at the end of the day. This is a case of myasthenia. So from the constitution symptom, you can know the complaint or the diagnosis. Vision problem, along with the dropping of his eyelid. You can add it to your question in the vision, okay? And whenever you are talking about vision, immediately I advise you to talk about driving, as you did. From first presentation, you have any vision? Yes. Do you drive? Yes. What do you drive? I drive my own car. Please stop driving until addressing your concern or your problem or diagnosis. Okay, doctor. Then proceed for the systemic review question. Any past medical history, of course, you have to ask. Thyroid disease means autoimmune association. Type 1 diabetes, thyroid, primary biliary, autoimmune hepatitis, vitiligo, and premature ovarian failure. We mentioned them every session. I think last week also it was there. Addison. Okay. This is regarding the systemic review, past medical history. And the systemic review, as you said, there was weakness or respiratory issue, difficult breathing or short of breath. The family history could help, yes, as I mentioned in the video of family history, the autoimmune cluster in family. So whenever the family, any one of them has a family history of autoimmune disease, the family, all family might have the disease not as an inherited one, just as running in family without genetic inheritance. So you might have his father or his mother with Hashimoto thyroiditis, for example, or thyroid disease, type 1 diabetes, or whatever of the situation or the conditions we mentioned in the autoimmune association. So the family history is very important. I think you asked it or did you forget? Dr. Lee.
Family I haven't asked.
Okay, take care about it.
Yes.
Yes.
Dr. Balim, also the issue of impact. You did not ask me about the impact. You know, about because impact can be very, very. They take it.
Of course,
very
yes.
serious to the exam. How it affects my. So you did not also ask that also.
Yeah, perfect.
parts.
Whenever you
Yes,
ask about the occupation, do you drive?
yeah.
Do you? What's your job? Do you smoke? Do you drink alcohol? What's your job? What's the impact on your job? He's retired. What should I ask? What's the impact on your daily activity? No patient will come to you unless his daily activity or his job will be affected. Some patient can tolerate further, but at 1 minute or at 1 day, he will present to you, doctor, I cannot tolerate anymore. I cannot do my daily even activity. If he's trying to tolerate and accommodate, but at one or some point he will come to you, doctor, I cannot tolerate. These points will give sense to ask or to make it will make sense to the examiner to ask about it. And it's not only the examiner, it's one of the mandatory points you have to ask in the clinical communication. And I know a lot of candidate who has marked down because of the impact and the feedback definitely written there. He didn't ask or the candidate didn't ask about the impact on his daily activity or on his job. Okay, so remember it whenever you are asking about the occupation history. The travel, I don't think it can make sense here, but the medication, yeah, we forgot the medication list or the medication history. Some myasthenia gravis patient will present because of crisis after certain triggers. So from this point, Dr. Ibu, what are the triggers for
Blockers.
myasthenia crisis?
I was using blockers, so I
Okay,
asked
this
him.
is yeah, this is in sense scenario. I'm not talking about this scenario in particular. I'm talking in general. What are the myasthenia crisis or what are the trigger for myasthenia gravis? Give me some example apart from medication. Medication, okay, beta blocker. What else? Okay, from medication, what other medication can trigger or can lead to the crisis? Very important medication, and give me example of it.
Aminoglycosides.
Yeah, this is as antibiotics. So you can mention antibiotics, not only aminoglycosides. A lot of antibiotics.
Antibiotics.
Yeah, on top of them, aminoglycoside, gentamicin,
Yes.
whatever. Okay, what else? What other
Then there
antibiotics?
are quinolones,
Tetra, tetracycline or
cyclin.
yeah, macrolide, and what else?
Then I think retinoids.
Sorry,
I guess.
what else you mentioned?
I think there must be some eye medications as well.
They are 4 antibiotics:
Yeah,
gentamicin,
yeah,
tetracycline, macrolide, fluoroquinolones.
perfect. Okay, thank you, Dr. Hind.
Genta tetra, macro, fluoroquinolones.
Okay, thank you.
Okay, this is regarding the antibiotics. So, 4 antibiotics you can mention. And you might have it in the exam. Patient has antibiotic for infection, upper respiratory infection, and started some medication or some antibiotics. Okay. Next, what other medication can trigger?
And then the like blockers in this case.
Okay, beta blocker. What else?
And the rest are like
Something the
I
patient will
guess,
tell you. Yeah, sorry.
but we don't use them. They used to be mnemonic about penicillamine, but we don't use them penicillamine anymore. So penicillamine can also do it.
Still, you are talking about okay, benzylamine. This is as old medication. It's not using anymore. Yeah.
Not
What?
not used anymore.
Yeah, yeah. Okay. What else? Not as medication directly or systemic. Other medication can be used in hospital, inpatient.
Anesthetic agents, you're talking to?
Yes, yeah, anesthetic agent. So patient will tell you, doctor, I had any surgery, whatever the surgery. After surgery, the patient will have crisis because of anesthetic agent and stress, infection. So don't be restricted to medication. Also stress, surgery, okay, infection, all of them can lead to myasthenic crisis. And as Dr. Hind mentioned, the antibiotics, you have to know them. Okay, this is regarding myasthenia crisis.
Triggers.
Yeah, you have to know. Yeah, you have to know them. This is regarding the clinical communication. We are done with the history, the impact. Smoking, you already addressed.
Smoking, I asked him to stop
Yeah,
it.
yes, I know. Yeah. Okay, the alcohol as well. Okay. Let's go to the next skill, differential diagnosis. Give me differential for eye or vision issue plus chest manifestation. vision, and chest. If you give me 3 in the same system affected, you will get full mark in the differential diagnosis, although you didn't mention it in the previous discussion. Vision and chest in paces. Okay, one of them myasthenia gravis. What else?
Yeah.
MS.
MS. Why MS will affect the chest?
The
No.
chest will not be affected by MS.
Yeah, it's not. So it's not one of them. Anyone knows can write in the chat box.
Chest and eyes.
Okay, don't look at the chat box. This question for you, but others can write in the chat box. But for you, you can answer without looking at the chat box. What are these 3 conditions, or name 3 conditions in paces?
Dermatomyositis or polymyositis.
Why dermatomyositis will affect the eye?
It will not affect the eye.
Yeah, heliotrops rash, it's not to the eye. Vision, I'm talking about vision.
Eye and chest both.
Okay, vision affection plus chest.
Small cell cancer, thyroid disease.
Thyroid will affect the chest. Why? Okay, if there is compression to the airway,
Yes.
but it's not directly to the chest. You mean
It can,
breathing?
yeah,
but
it can
it's-
affect the breathing. It can affect
Okay,
the
I'm talking about
retrosternal
l-
extension,
lung.
the lungs. Okay, small cell cancer, cancer from Pacos tumor.
Pancreas? Talking about
Yes.
Pancreas?
Perfect. Yes, this is the
Pancreas,
second.
okay. You mean
Yeah.
Horner with that?
Yes, Horner. Perfect. Pancreas,
Horner.
Horner, chest. Okay, lung cancer, pancreas tumor, and Horner, as we said. One more condition. Who will do it?
Thoracic duct.
Let's see, Graves might no Graves. Okay.
No, it's aneurysm.
What? Sorry.
Ah.
Okay, it's one of the common presentation as apical parenchymal lung disease. To be more specific.
Ankylosing spondylitis.
Perfect. Again?
Oh,
Yes.
ankylosing spondylitis.
Sorry, okay, ankylosing. Yes, the same as ankylosing and the other condition Dr. Hind already wrote it.
فنان
Ankylosing.
فنان يا دكتور بس خليتنا
Yes.
كنا ندور على الديفرنشال. بصراحة
Okay.
الساركويدوز والانكيلوزنج يوفيايتس
Yes.
you are right.
Perfect. Yes,
Uveitis
perfect.
and interstitial lung disease.
Yes.
I agree with you.
Perfect. So sarcoidosis and closing. So by the thinking and brainstorming, 2 conditions appeared. I meant really sarcoidosis, but ankylosing also can be perfect differential. Because all of them or both of them can cause uveitis. Agree? And both of them can affect the vision along with the parenchyma or the lung affection. So, and the myasthenia, by the way, it's not parenchymal lung disease. It's just movement or respiratory muscle. And she's
Respiratory weakness.
exactly. So it's weakness.
Neuromuscular.
Exactly, neuromuscular and weakness rather than parenchymal lung disease. Anyway, it's a good differential. Thank you, everyone. I can see a lot of you
But
help.
really, botulism is a good differential.
Yes,
One of
botulism, of course.
diplopia, it will lead to diplopia and also respiratory muscle weakness. Botulism.
Yes.
Oh, yes.
I wrote GPS. I remembered Miller-Fisher syndrome.
Yes, Miller-Fisher.
Yeah,
Yes.
it will be very far. Miller-Fisher ophthalmoplegia and like the standing
Areflexia.
can affect respiratory muscle. But whatever Dr. Bassem mentioned is more common. Myasthenia gravis,
In exam. Yes.
sarcoidosis. We can add oculopharyngeal muscle dystrophy.
Okay.
We can add botulism. But those are really a good differential. Some of
And
them by interstitial, some of them by respiratory muscle weakness.
Yeah, and pancreas tumor, Dr. Hind, as
Pancreas is very good
Horner.
differential. Yes, because
Exactly.
I mentioned it after myasthenia. Really, as a common
Yes.
eye. And if you are thinking about paces wise, You should
Yes.
think of myasthenia gravis and muscle dystrophy whenever it is like diplopia and ophthalmoplegia. When it is Horner and the chest pancreas is a very good differential.
Yeah, perfect.
And
Myotonia
whenever
dystrophy.
it is like uveitis and red eye, think
Yes,
of sarcoidosis and ankylosing spondylitis.
perfect. Yes. Myotonia also mentioned here also. How the myotonia can be
Myotonia,
affected.
not myotonia, muscle dystrophy, because oculopharyngeal, usually myotonic dystrophy is less likely to be associated with ophthalmoplegia.
It's
We
not
really
as ophthalmoplegia, doctor, and it could be as ptosis. So,
bilateral torsos, yes, I agree with you, صح. So we are
yes,
talking bilateral torsos, yes.
yeah, perfect. Again, it's respiratory muscle. So,
Respiratory muscle weakness, yes.
yes, exactly. Okay. Thank you, Dr. Kani and Dr. Hind. Other Dr. GBS, botulism, perfect. Dr. Nada, yes. Muscle dystrophy, myasthenia gravis, thyroid disease. Thyroid, as I said, Dr. Ola, it will be airway rather than lung or respiratory.
Expression.
Exactly, yes. Graves' disease with this an extension, perfect, short of breath, mediastinal, yes, Dr. Hind, thank you. And also, the Pancos, don't forget it. It's one of the example in exam. They like this topic. Pancos along with Horner syndrome or complicated by Horner syndrome. Okay, this is regarding the differential. Perfect, Dr. Ibu. Then the next skill will be for clinical judgment. Again, whenever you have a disease could be presented as acute, please remember the ABCD approach. Myasthenia crisis or myasthenia gravis, if presented as myasthenia crisis, it's one of the life-threatening condition. Okay, sometimes either intubation or if difficult intubation because of thymoma or because of thyroid or goiter, they consider tracheostomy. So what I want to say, it's not an easy case, and it's the complication is life-threatening one. Challenging to have this. Whenever you hear the history, there is myasthenia gravis. Consider the intubation on presentation if he has airway or breathing difficulty. Okay. Sometimes the non-invasive might help, but if the CO2 is high or patient is losing his conscious level or the complication of respiratory failure, consider the intubation as emergency. Let's go to the investigation. I think it was mentioned, all of them, anticholinesterase and anti-muscle specific kinase. This is the specific antibodies for myasthenia. The bedside tests, single fiber electromyogram, you have to mention, and the bedside test as well, spirometry, ABG, pulse oximetry, all of them can help. You can do HS X-ray as imaging for thymoma to detect any thymoma. And for the invasive, you can consider the surgery. It's one of the management and investigation. If there is a thymoma, you can do thymectomy. But it's considered as management plan rather than investigation. You can do high resolution CT chest for thymoma. Okay, this is regarding the clinical judgment. I think you covered it well, Dr. Ibu. The concern, as I said, it was out of the time, but anyway, whenever the time is near to finish, don't answer the concerns in details. Be very short. You have not only one concern in every scenario. It's full of the concerns. And the examiner will judge in your answer in this scale according to how many concerns you answer and how correct you answer it. Even if you don't give a clear management plan, he doesn't care about it. He wants you to address the concern properly, whatever the answer. Okay. The last thing was thymoma, the welfare, and I think you covered it well regarding the driving and the other advices. Any comment, Dr. Ibu, or question?
Should I tell him about driving immediately or can we keep it later on?
So, as I said, whenever the complaint about the vision, from the start, vision means driving. as a complaint. If you want to put it as with the do you question, do you smoke, do you drink alcohol, do you drive? But to be sure that you will remember it. So what I want to say, whenever you remember it, address it. If you remember it while analyzing the vision, address it immediately. Do you drive? Yes, stop driving. Then forget about it. No need to repeat it. But if you are forgetting it initially, you can do it at the time of the occupational question. But for me, I believe you can do it on time. Whenever you ask about the vision, ask him if he drive.
طيب even
Sometimes, yes,
forget
yeah,
driving, even if you forget driving in the history, don't
in,
give up. Mention it in the
in
management.
exactly.
Non-pharmacological treatment while you are talking about education and counseling, because actually stop driving and DVLA is part of educating the patient about the disease. So don't give up. Don't give up if you forget it in the history, neither in the beginning or at the end. Mention it to the examiner that I would make sure that this patient is aware about the driving
Yes,
license regulation regarding his condition.
perfect.
Because
So you have 3 times to remember.
يعني, and I think if you did the case very well, it
Mhm.
will save your life. Because you did the case very well, you remembered the driving, it will not be a big issue.
Exactly, yes. Okay, Dr.
طيب
Hosni. Yeah.
إذا أنتوا
Thank
جاي
you very much.
عبالكم في أبديت لطيف بالمايثينيا جريفز، إذا جاي عبالكم.
But in English, Doctor,
Okay.
because, yeah.
There are 2 new scores الصراحة, because really this update is يعني about scores and about grading,
Mhm.
and this grading help you to choose the management option, so it was like interesting for me. There are 2 new scores in Myasthenia Graves, one of them called Myasthenia Graves Activity of Daily Living, ADL, MG, ADL, and another score called Quantitative Myasthenia Graves. The role of these 2 scores, one of them is history score. You have to ask about, because I think if you didn't really include those questions in your history, really you will be cut in the communication. The history question of this score are about speech, whether he have any difficulty or slurring speech, or hoarseness of voice. So these 3 have to be mentioned: difficulty or slurring and hoarseness of voice. Then chewing, any problem while chewing food, swallowing or choking, breathing, whether he's having breathing problem. If he said yes, do you have any shortness of breath even at rest? Because this can help you to grade how severe is the or how impending is the crisis. Then you will ask him about the overhead activity, for example, difficulty combing hair or brushing teeth, about the hip, proximal lower limb weakness. Is it difficult to climb stair or raising from chair? Then you are done with the generalized myasthenia graves. You will go to the ocular. You will ask about double vision. And this double vision, if it is all through the day, it can be all through the day. It's not necessary to be at the end. If it is constantly all through the day, you are dealing with a very severe ocular myasthenia graves. Eyelid dropping, droppy eyelid. Again, you will ask whether it is at the end of the day or constantly throughout the day. The beauty that you have to come out from the idea that myasthenia graves should have only diplopia at the end of the day. If the patient has severe myasthenia graves or he is on impending crisis, diplopia and droopy eyelid will be persistent. It will not be only after a period of fatigability. And also the opposite is possible. You will have a patient who have myasthenia graves and you will ask him, do you have any diplopia? Do you have any droppy eyelid? He will strongly say, no, doctor. Even at the end of the day, no, doctor. But when you examine him and you do the fatigability test, don't give up on the ceiling test. You will ask him to look at the ceiling and you will ask him to count. And it is not the wing beating test, Dr. Ipo. It is elevation of both arms, like he's doing pronator drift, but rather than keeping it for 20 seconds, you will keep it up. So if you don't have time, as Dr. Bassem said, it will not be the best way to do fatigability test. But let's say you are short of time and you are weighing risk versus benefit, you want to pass the exam, it's not the wing beating test which will help you, because that test will take time. Okay, do the ceiling, ask him to count while his both arms are up. Slightly
Yes.
while he's counting, the arms will drop, diplopia and droopy eyelid will appear, and husky or nasal voice will start to be prominent. Okay, which we call it ceiling test. If you have time, separate the steps. Keep the eye plus the speech together, and then do the wing beating or ask him to keep his both arms up, and then count, or at least for some time without counting, you will notice dropping. Okay, either of both or one of them, because sometimes myasthenia gravis is asymmetrical. Okay. So, صح كنا بالسكور. So after the double vision and eyelid dropping, remember that it can be like a wide spectrum from no and you provoke it in the examination up to constant, not only at the end of the day. Okay, so these things are very important whenever you talk about myasthenia, because usually myasthenia gravis is a very easy case, so it will not come typical. Yeah, they might play with the symptoms to make it at least slightly tricky. Then don't forget about the triggers. As Dr. Bassem said, he mentioned most of them. If she's a female, please ask about recent delivery, pregnancy, when is your last period, because pregnancy usually unmask subclinical myasthenia gravis. Any recent surgery. They might not use the muscle blocking agents which induced myasthenia, because now those agents are like old fashioned. They might use the new agents which don't induce myasthenia, but surgery itself is a stressful situation and it can trigger crisis. So recent flu-like illness, upper respiratory tract infection, gastroenteritis, any recent antibiotic course, it will hit both purposes. It will hit the trigger. There was an illness. What you took for your illness? I took an antibiotic and I stopped it a few days ago. Okay, bingo, I catched something. And sometimes the patient himself, he joined a new job, he joined the gym, he increased his exercise level, so it unmasks his underlying myasthenia gravis. And please don't ask only about medication history and any recently start or stop medication. What you should also include in your medication history.
Supplements?
Yes, because magnesium containing supplement is a killing hidden trigger. Magnesium containing supplements. Okay, and this is very common. You will find him. He joined the gym recently, so his exercise level has increased, and he started supplements containing magnesium. So you catch two triggers in one question. Okay. So those triggers usually also they play with the triggers. It's not always like, easy to pick. So remember any flu-like illness, any recent surgery. Did you receive, as Dr. Bassem said, any anesthesia? Travel history. How travel history can be significant in myasthenia gravis? You people will be astonished after I will tell you. What the patient take if he went to an endemic area?
Any vaccine?
Chloroquinolone.
Oh yeah, chloroquine. Yes,
And
that also aggravates.
chloroquinolone is a trigger. Simply,
Yes.
he was okay. He was fine. He traveled. He took malaria prophylaxis. When did you came back? I came back the last week. He should continue for 2 weeks on the prophylaxis. So, doctor, did they start you on a prophylaxis? Yes. And are you still on them? Yes, because they told me I need to continue the prophylaxis for 2 weeks after I come back from the travel. Bingo, I catched something. Okay.
Yes, perfect.
So يعني these things are, do you know, um, train yourself for the full scheme. Don't cut your scheme except if a crisis happen in the exam. The surrogate is difficult. Some part of your time was wasted because of arrangement thing. Then try to cut, but otherwise, believe me, whoever put the history scheme, he knew that every single question is valuable. I agree with Dr. Basim. I don't disagree with him that the travel history, if we rank the travel history, its importance among the other questions, it will get the least rank. I agree with him. And I can sacrifice simply, but just like because we're revising. So I raise this point. Okay. But I agree with him that if I need to sacrifice with something, it will be the travel history. No need to ask because mostly if he's on any medication, he might really volunteer without asking about the travel history. But it might have a correlation with the condition. Now we finished the myasthenia gravis ADL activity of daily living score, which is really a questionnaire about the daily life activity which is affected by myasthenia gravis. Indirectly, it serves us to make a good communication skill. We ask about all the questions. Okay. Now, don't forget that usually, whenever you are talking about myasthenia gravis, you have to exclude some differential. So, whatever questions you will add, it will be for thyroid, for myotonic dystrophy, for botulism, for those stuff which we mentioned that they are a very close differential. Okay, the second score is a very valuable score for which is the quantitative myasthenia gravis for examination. It is about ptosis, okay? And remember that Horner, if you ask the patient to look up Horner, the ptosis which is associated with Horner will be corrected because it's a very small muscle and the levator palpebral muscle is working. It's the Molen. I think it's called Molen muscle. So that one is a minor muscle. So if he need to look up, he will use the levator palpebral muscle and he will be able to elevate his eyelid. So Horner will be corrected. So ptosis in myasthenia gravis and in third cranial nerve palsy is never corrected by looking upward. Okay? You have to correct ptosis by your hand before examining for H-shape movement and visual acuity. Don't do the examination without correcting ptosis. You will lose the marks of those steps. So you will take the permission of the examiner. Can I ask the patient to elevate his eyelid? If he agree, the myasthenia gravis will not be able to do this. Why? Because he have overhead activity difficulties because of the proximal myopathy. So you will ask the examiner to help you. So the examiner might be holding the eyelid and you will do the visual acuity each eye alone, then the H-shape movement to pick up the complex ophthalmoplegia. And I think you asked about pain and you observe for nystagmus. I really forget your steps, but don't forget to keep those in your extraocular muscle examination of the eye. So we are done with ptosis and the tricks which come with ptosis. Then you will do the diplopia with the fatigability. You might do the H-shape movement, no diplopia. Remember that you need to provoke diplopia. Then you will do the facial muscle examination. I don't know if you did. I think you people
I did do.
commented. Yes, you commented that it must be done upper and lower. Okay, you might find there is bilateral muscle weakness, not facial nerve palsy. Okay, this is a muscle weakness. Then you will do you open your mouth, say ah, give me a cough, and by these two things, you will be able to assess the bulbar weakness. And immediately, please don't wait. As I think, what is the name of the other doctor?
Dr.
The one
Henry.
who did the case.
Dr. Henry.
Yes, Dr. Henry, he said that you need to assess swallowing. Please, immediately say, I need to assess the swallowing test. There is a bedside swallowing test, can be done by us as a general doctor. And there is a specific swallowing test, can be done by the SALT team. But you mentioned generally, I need to do swallowing test for this patient and gag reflex, but don't do it, offer it. Okay? The speech will be assessed by the ceiling test. When you ask the patient to count backward, we always forget neck flexion and neck extension. Guys, this is very important. Since we started myasthenia gravis cases for a long time, nobody's mentioning it, but it's very important. And
Yes.
whenever it is positive, it's an indication for impending myasthenia gravis crisis.
Yeah, this I read it somewhere on Instagram. I mean, neck flexion
Okay, so neck
weakness is
flexion and neck extension. So don't
true.
forget it. Even if you didn't do it, because some of you immediately will come to his mind, okay, I have a lot of steps. Guys, offer it, offer it, offer it. You have the liberty to offer. So I would like to examine the neck flexion and extension along with the forced vital capacity and the other breathing test with chest expansion. Okay, then you will ask the patient to do the wing beating test, or you might not need the wing beating test if the patient already have obvious proximal myopathy. Don't do the provocation test if the against resistance is already weak. Okay, offer, because the patient will be even more weak. So if you find that proximal myopathy is positive, look at the examiner, tell him, do you want me to do the fatigue? Don't say wing beating test, because this is against welfare. It's not a nice term to mention it. Tell him, should I do the adduction, abduction, fatigability test? He will tell you, do it or no need, because already when you did a resistant at the first place, you got your results, okay? So be careful what you need to offer and what you need to do. But if the patient show you a good resistance initially, go for the provoking test without asking the examiner, because it's justifiable. You need to provoke the proximal myopathy. Okay? Then ask the patient to stand from sitting position without support to illustrate the hip weakness, hip flexion weakness. Okay? So the patient will need support to stand. Now you will need to do chest expansion if you have time. And there is a very important test called single breath test. Dr. Imad, Dr. KJI, all those tutors, they found the test mentioned in the feedback, because you might not get time to do the chest, the forced vital capacity. You will not do it. But you can ask the patient, you have 20 seconds, please show me how many breaths you can take. If he take in 1 minute 20 breaths, perfect. If he took less than 15 breaths in 1 minute, single breath test is positive, and this is an indication for ICU admission. So this can be done, okay? And it is the fatigability test for the respiratory muscles. It's called single breath test. It is very, very important. No time to do it, please offer it. Along with the forced vital capacity, the chest expansion, and the pulse oximetry. Okay? So now the accessory بنسميها بالعربي فزلكة ice pack test. You might offer it if you have liberty of time, or the examiner might tell you, do you need, there is a very like old bedside test. You can tell him ice pack test. Whenever you place an ice pack over the eyelid, the ptosis will disappear. Okay? Because the cold weather improve the neuromuscular junction transmission. So the ptosis will disappear. I advise you, don't bring the curtain sign into the game, because already you are busy playing with many things, so you will not have time to mention the curtain sign. Along with the, sometimes really when you mention something which is very deep and you forget something which is very obvious, the examiner will become like, irritated, and he will start to be picky and more stubborn, and he will concentrate on your weak points more. Because how come you are mentioning something which is like very too much detailed, and you're forgetting things which are essential? So curtain test, whenever you will, if you have two eye which have ptosis, one more than the other, so you will pick the eye with severe ptosis. You will innervate the eyelid, so you will hold the load. You will take the load. The severe eye, which have ptosis, suddenly the other eye, which have less ptosis, it will drop. It will become severe. That's why they call it curtain, as if there is a curtain and you bring it down. Okay? This is the curtain sign. And it is something related also to the brain hyperstimulation to correct the ptosis. So don't bring it, but at least we revise it since you mentioned it. So the curtain sign is something you don't have to do it in the exam. It's not part of the scores, and it might not be even diagnostic. It's just one of the signs which is usually can be discussed for neurology purpose. If you get the case, for example, neurology station, and you were too much perfect, one of the examiner might ask you what extra ocular sign you can offer. You can mention peak sign, curtain sign. I don't know, there was many signs in OST, so you can go through them. But this discussion might raise in the station 3. Now, based on the myasthenia gravis ADL and the QMG, you can offer treatment. There is some numbers. We don't care about the numbers, but what you should know, that you will calculate those two scores. If they give you a mild disease, whatever the calculation is, whatever the number, it give you based on these scores, the patient have mild disease. You will go immediately for which option?
Mild, you will go with the pyridostigmine?
Yes, as simple as pyridostigmine. It's what we call it between brackets symptomatic therapy. Okay, so it is, what is the mechanism of pyridostigmine?
Acetylcholinesterase inhibitor.
Cholinesterase inhibitor. It will increase the level of acetylcholine and improve the transmission in the neuromuscular junction. Now, if I did the calculations and I get numbers which indicate a moderate to severe disease, what is my first option of treatment?
Steroid.
Yes, corticosteroid plus
Corticosteroid.
steroid sparing agents. As simple as that. Nobody gonna ask you what is the steroid sparing. If you were asked what is the steroid sparing agents, there are
Is
new
that
new monoclonal antibodies and biologics, like anti-C5, complement 5, rituximab sometimes is used, whatsoever. But nobody gonna ask you. But I will not start by rituximab if I did the scoring and I get moderate to severe. And don't forget that steroid usually, whenever whenever it's mild and you start pyridostigmine, you can treat the patient without admission. No admission. No need for admission. Pyridostigmine, and he can be discharged and follow up in OPD. But whenever it's moderate to severe and I need to start steroid, there is what called steroid dip phenomena. It's mentioned
Yes,
in
yes,
class
yes, yes, yes. Yes,
steroid dip phenomena. So
the
this
phenomenon.
will lead to paradoxical worsening in
One second.
myasthenia gravis whenever you initiate steroid. And because of this dip phenomena, the patient should be under strict monitoring inside the hospital when you
Yes,
initiate
yes.
steroid. Okay, so you need to admit the patient, and your first option will be steroid as long as you have moderate to severe disease based on the scores which you calculated. Now, if the patient fulfill the crisis, no scoring, because crisis is a clinical diagnosis. Okay, it's
Ye-
different.
Yes.
Crisis is a clinical diagnosis, and you will have, rather than score fixed number, deterioration in the rapid deterioration in the scores. He will increase more than 3 to 5 points in each score per day. This will predict that the patient is going to enter into a crisis, and plus the clinical signs and symptoms that you have. So this patient, as Dr. Bassem said, and Dr. Henry, and you, Dr. Ipo, ABCD, admit to ICU, prepare for ventilation, keep the patient under regular, they sometimes they do it Q2 hourly, forced vital capacity or single breath test in order not to exhaust the patient. Okay, and be prepared for plasmapheresis or IVIG,
Yeah.
positive, negative, steroid along with plasmapheresis and IVIG. Okay,
Perfect.
so this updates why it's beautiful, because whenever I have scores, it will teach me what I should not miss, since those scores are like a diagnostic points. Okay,
Mm.
so these two scores are new scores and they are really helpful if you read about them. And always whenever you mention steroid to any patients or to any examiner, you should be careful that this steroid should be tapered slowly and the stuff which come with the steroid, because the examiner might touch this point. Okay. and bone protection, gastric protection. Please take
Gastric
care.
protection.
Some people they forget about the whole myasthenia gravis stuff, and they ask you, doctor, you will start steroid. Do you want to ask for anything else? And your brain is with the myasthenia gravis, and his brain is with the
Yeah.
steroid. So take care to remember that I'm mentioning steroids, so I should remember that steroid need tapering, bone protection, gastric protection, and those stuff. Okay. And don't forget to mention regular follow-up because those scores, especially the one which is related to the activity of daily living, should be repeated in order to know whether your treatment is effective or not. And if the scores are improving, you will continue the same treatment. If the scores are not improving or deteriorating, you need to escalate your treatment. So whenever there is a scores, there is a strict follow-up because the score will guide my treatment. Okay, I'm done. I talked too much, but I liked the update too much. So I
Okay.
wanted to share it with you.
No worries, Doctor. Thank you too much, Dr. Hind. If you can share this update to the WhatsApp group, we'll be more thankful.
I will share it harder.
Yes, please. One more point I remember while speaking about the steroid as a trigger. You have to ask if this patient received the steroid recently or before the attack, because again, it's treatment and at the same time, it could be the trigger.
The dip phenomena can happen at any time he will
Exactly.
receive steroid while he is on the.
Yes.
You're right.
So yeah, you can add it to the medication can trigger or can lead to the myasthenia crisis. Okay, thank you again, Dr. Hind. Anyone want to add any comment or question?
But really, thanks, Dr. Bassem. And the way you revised, even the autoimmune association, mashallah,
Thank you very much.
Yes, I want just to add one thing. Don't forget to shake the hand of the patient because usually the examiner would understand that since the patient have bilateral ptosis
Yeah,
and bilateral fascial
myasthenia
weakness,
dystrophica.
yes, he will be very happy by shaking the hand of the patient because he will understand that the muscle dystrophy, let's say, in general, muscle dystrophy, including myotonia dystrophy, is in your mind. So shake the patient hand, please. Don't forget, Yani, okay?
Yes, yeah. It's one of the short station as well. We did it many times before, vision or examination of the vision, and you notice the facial or the face of the patient is characteristic for myotonic dystrophy. So put the myasthenia as a differential and the shaking hands in this scenario as a short. One of the mandatory tests you have to do for myotonic dystrophica.
Agree. It will
Yeah.
become more important if it is station 3. And
Yes.
don't forget that sometimes even offering the deep tender reflex is important because the deep tender reflex is usually
Hyperthyroid.
abnormal in Lambert-Eaton and normal in myasthenia gravis. So since Lambert-Eaton is a very close differential and even thyroid Graves' eye disease, so deep tender reflex is one of the valid things to offer doing it in the examination. I know
Yeah.
that it is many stuff, but believe me, when
Yes.
you know everything and you go inside the case, it will be easy for you to bring some stuff in your discussion and to ignore some stuff. But at least you know what I should bring early,
Yes.
what I should offer, what I
Yes.
should discuss later on. Even sometimes if you forget anything in the examination. For example, you forget forced vital capacity, single breath test, you forget deep tender reflex, you forget whatsoever. Whenever you start with the investigation, start with what we call bedside observation or bedside test. I would like to run some bedside test, including. Then you go
Yes.
to the laboratory. It's totally okay. Oh, so it will help you to be relaxed. So I will be able to manage even even if I did a drop in any point, I can like compensate for it later on.
Yeah, perfect. So I can revise all these things. If I forget it in the examination, I can add it to my investigation as bedside tests. It's a third chance. History, examination, and the discussion with the examiner. Thank you again, Dr. Hind. Thank you, Dr. Hina and Dr. Ibu. Any question? Any comment from anyone? No question? Really appreciated, Dr. Hind, your talk today.
Thank you so much.
It's
Yes,
more, yes.
amazing, amazing.
Yes. I think it will be helpful for all, informative as well. So see you tomorrow, inshallah, with the communication day. Good luck and good night. Assalamu alaikum wa rahmatullahi wa barakatuh.
Yes.
Assalamu alaikum.
Assalamu alaikum.